I found taking care of patients to be particularly rewarding, and cardiology allowed me to both work with patients and also talk with their families, but also really get involved in their care. And cardiology over the last 40 years has blossomed. We've had very little medications 40 years ago, but now we have stents, we have medication for heart failure, we have advanced care. And so it's been an amazing career just to watch things grow. Cardiologists who come into practice right now don't really know where we've all evolved from 1975 when we didn't even know bypass worked. We had very little understanding cholesterol to what we have right now. So it's been exciting growth. When I look at smoking, obviously, is probably the one most modifiable risk. And I think the country has done very well with that. But our patients, the few patients who come in with large heart attacks now, most of them are smoking. Cholesterol management has changed tremendously over the last 30 years with the statins. And I think that's made a major impact. Once my patients are on statins, their chances of having a major heart attack are diminished significantly. Obesity is, I think, the newer thing we're going to be working with the GLP agonists. I think they are really a wonderful drug. For that, they've shown to reduce heart attacks. And probably that's going to be true not only in diabetics, but in overweight patients. Hypertension is obviously important. I'm not sure where that actually fits into things now. It's one of the modifiable risks. And then situational, economic disparity, obviously, is something that's very important, along with diabetes. And I think what we see, at least in the U.S., is the social economic disparity among populations is availability of getting real care is a major predictor of what's going to happen. Basic cardiology means we're not putting ourselves stents in or putting the valves themselves. That's more. There's interventional cardiologists who put in stents, they put in valve stents, they put pacemakers in, and then there's also surgeons who are not considered cardiologists, considered cardiovascular surgeons. So our job is to see the patients and take care of the care from the moment they come into our practice, either in the emergency room or through referral. And then really, I take care of patients over the last 30 years. So I've seen them grow from 50-year-old people who had heart attacks, a smoker, overweight, high cholesterol, and now they're 80 years old and they're functioning very well. Now you worry about things like, having strokes, getting older, hip problems, knee problems, Alzheimer's disease, things like amyloid. So it's a totally different thing. I've watched my patients grow from being younger, healthy people, and now 30 years later, they are in their 80s, but they're still functioning. And for me, that's the real reward, to watch them over 30 years and watch them remain active and watch the disease actually held in check. I think for me, as I talked about, the biggest advancement we've had is the treatment of cholesterol. And I think statins have made all the difference. I think back to the number of patients who came in with major heart attacks, who now are on statins, and probably less over the last 30 years, probably less than 10 of those patients ever come back in with a major heart attack once they're on statins and stop smoking. So I think that is the biggest change that we've made. And everything else after that is more incremental. So we've had further reduction agents, such as the injectable agents that we can now use, other pills that we can use. So that's one thing. The second thing probably is as people get older, they get atrial fibrillation, which puts you at increased risk for stroke. And back 40 years ago, we didn't know whether we needed to anticoagulate these patients. We finally had a big study that showed it made a difference. And so we now transferred from warfarin to the newer agents that was called the DOACs. And those are things like apixaban or rivaroxaban. And they have actually changed how we treat AFib right now, because now we can use a drug which is much safer, especially apixaban, as far as caring for them. So I think those are two things. Heart failure is the third thing where we made a big difference. Back in the 80s, we really had no drugs, and now we proved the beta-blockers, ACE inhibitors, MRA inhibitors, and SGLT2 inhibitors. All this, so we have 4 new classes of medication for which we can treat heart failure. And then obviously there's hypertension, but we've had more medications for that, but that's probably more incremental. So I think probably lipid lowering, heart failure, and anticoagulation are the 3 biggest areas I've seen that really change. And everything now is more incremental. You're looking for a new improved drug. The ones we're seeing for cholesterol are different agents to look at. but they have a 3 or 4% reduction of events over 3 or 4 years. And then now one of the bigger things is for a drug for amyloidosis, which is a disease of the elderly, where there's deposits of proteins. And I think that's probably one of the newer diseases that we're discovering how to treat. I mean, it's out there, but now we have drug therapy. So I think that's probably the one where I'm really excited. It's a disease of the older people, and I think that the new and improved drugs for amyloid is going to be one of the major changes over the next 5 years. As I said, I think probably we can now treat heart failure, and so we can treat reduced ejection fraction heart failure with the drugs I mentioned. We're also looking at older people with what's called preserved heart failure, where the heart is strong but probably stiff, and so we need to get better understanding of how to treat them. So it tends to be people who are older, more likely to be women, and what we found is our treatment there is still lags behind. So if I think there's anything we're looking at where there are further advancements, is treatment of heart failure with a preserved heart function, where it's actually strong, it pumps well, but it's stiffened. So that's probably the one area where I'd like to see advancement. And everything else, I think, is incremental. We have new lipid-lowering agents. One of the problems with statins is about 20% of patient population can't tolerate them higher doses because of muscle aches, and there is a slight increased risk of diabetes. So I think the newer agents which we're using hopefully can overcome that. And I think the other thing that's actually very important is the cost of medication. And a lot of the medications we have now for heart failure probably have 3 or 4 more years of before they become generic. And I think one of the bigger problems with cardiology now is the newer drugs, the better drugs, are costly. And so that causes problems for our patients, like the DOACs, the anticoagulants. They are more expensive, but in 2 or 3 years they'll become generic. So I think as the drugs we're using now become generic, they'll become more affordable for people, and that may make a big difference. I think one of the things that we're looking at now, there are calcium scores, which are cardiac calcium scores, where you actually do a CAT scan and you can actually identify whether there's any calcium buildup in the arteries. It's not a direct angiogram. It's not a one-to-one correlation, but we tend to use that now in our patients who are in their 50s or 60s to see whether they're at risk for heart disease. And those patients then can be treated much more aggressively. So in our practice right now, that's probably number one as far as what we're looking at to help screen for patients. The newer data over the last couple of years is about inflammation. And there's a lot of data regarding high sensitivity cardiac reactive protein, and that shows underlying inflammation. And right now, there's treatment with colchicine for that. And so we're looking for patients who are at higher risk based on that. It's called residual risk. The next thing is LP(a), which is an agent which is genetic in nature. It's probably 10% of the patient population. It's probably increased in Africans and Southeast Asian, and that puts that patient population at higher risk. And there are 3 or 4 ongoing studies now to see whether we can develop a drug which will treat them. That is not modifiable by diet. It really is only modifiable by treatment. Some of the other agents can reduce it by 25%, but we're just getting an understanding of that. So the 2 things that I'm doing right now to look at increased risk are calcium scores and LP(a), and then the cardiac CRP. So the 3 things. So those are the ones that are traditional, that are out there. I read about genetic markers, and somewhere back there, they're talking about looking at like 300 or 400 different markers and seeing who's at higher risk. So I read about that. I've seen it. I haven't started using it yet. I don't know where you go with something that gives you a slightly higher risk of doing something. The treatment actually, in all honesty, for higher risk is, weight loss, treatment of diabetes, but also aspirin and statins. And there's a big controversy about when to start using aspirin and when to start treatment with statins. So I think if we can see the modifiable risk, we know we can do it with them. And if there are genetic markers that we can find, and I've seen out there just some data that suggests there are some studies going on, then you know which patients need to start on statins and aspirin earlier and which don't. So I think maybe what they're trying to do is something which will cause a bifurcation, which is, yes, this person has high LDL, but they don't have any other markers, so let's not treat them. Or they do have all this, and let's get them on statins and aspirin earlier. So that to me, if we have something which can help, that bifurcation would be helpful, because the bifurcation really is, do we treat them with statins and aspirin, versus not. We lean towards lifestyle modification, which doesn't work. The amount of patients that actually do this are very minimal. So then we go to medication. Obviously, if you have a genetic problem and you have Lp(a), you can do all the things in the world and you're still going to have a problem. And if somebody's massively overweight, then really GLP agonists or bariatric surgery is of value. And stopping smoking. So stopping smoking, obviously, is the first thing that's modifiable. Weight loss is the other. And then I like the South Beach diet, which is, for things with glycemic index. Those are really the only three things we can do. So smoking, obviously, is the easiest thing to do. And ironically, in our practice, we can tell when somebody's smoking because 95% of patients are not smoking. And somebody walks into our office, we know they're smoking. And I think that's the biggest modifiable agent. If you're still smoking, you have heart disease, you're in trouble. I think what I've seen, women probably have a little bit delay towards disease, and so there's a 5 or 10 year delay of disease. But you have found that the women who have hypertension during their pregnancies probably develop vascular disease earlier. So I've started looking at women who have preeclampsia or hypertension in pregnancy as being an increased risk. But then the patient populations which we look at as being high risk are the Southeast Asian and the African patients, and African American and South African as being at higher risk. And also the other thing is there are different patient populations which deal with how they break down drugs. The Korean population, a lot of the drugs that we use have different metabolism, especially the antiplatelet agents. So they're not necessarily at higher risk, but how they metabolize drugs, it puts them at different risk. I think that it's another risk that they have, and so I will look at my Southeast Asian patients and African American patients and look at them as higher risk. They also, as you probably know, for African American patients, they respond differently for hypertensive medication. They'll do better on diuretic medication and calcium channel blockers than some ACE inhibitors. So I do look at patient populations as how they will respond, but in the end, they just still are higher risk, and so you just treat them earlier and more aggressively. I think the biggest one for me right now is the Lp(a) issue. That is because I've been screening it very carefully. I don't have a 10 or 20% percentage of my patients having Lp(a). I'm not sure why that is. It may be that I'm treating them very aggressively. Maybe they're bringing the Lp(a) down a little bit. We also don't have a huge Southeast Asian population in my practice. And we're in a suburban area, we probably don't have a huge African American patient population as of yet. So that may be why my patients don't have as high a percentage of Lp(a). But the ones I do have, there is a physician about 20 minutes away who actually is doing studies. So I think the biggest shift right now will be treatment of Lp(a). And then the other one will be the cardiac CRP that Dr. Ritter has been proposing. Those are the ones I think have incremental changes. And we talk about residual risk and absolute risk. And so residual risk is what's left after you've done everything else. But that becomes a smaller, change that we can make. They talk about relative reduction and absolute reduction. So if you have 20% event rate and you drop it by 25%, you now go down to 15, which is a 5% absolute reduction. If you have a 2% risk and you drop by 25%, now it's 1.5, but your absolute reduction is only 0.5. So I look at absolute reduction, which is also the number to treat, how many patients we have to treat to do this. And so I think absolute relative reduction is important, but if you really want to know how much the medications can make a difference, it's absolute reduction. And if you can get 5% absolute reduction, you made a big change in your population. With 0.5, you made much, much smaller. But in both cases, the relative reduction has been the same. So I tend to look at absolute reduction or number to treat as being most important. I think that a lot of what we're doing now is actually is electrophysiology. So I'm not sure that's non-invasive or invasive, but pacemakers, AFib ablation, stenting. So I think that that's been probably the biggest advances that we've had. Advances is really that we now can treat valvular disease with stents. We can treat AFib with ablation. So I think to talk about non-invasive as being the biggest shifts, I think the biggest shifts I've seen is the Watchman procedure for AFib, where you don't have to go on anticoagulation anymore. The fact that you can put stents in people who are 85 years old. And so I see actually the biggest changes for my patient population here in the 80s is we now can treat them, maybe get them off medication. So that's not really an answer to what you asked me to, but that's the thing that actually changed the biggest for me is TAVR and AFib ablation and Watchman. I think we talked about, the Watchman procedure for AFib, which ironically will mean you will not need to be on anticoagulation forever. And I happen to think if there were enough EP doctors out there to put these in everybody, that the treatment for AFib might be Watchman rather than anticoagulation. They're talking about the new anticoagulation treatments with the factor 11 factor, whether that drug, which causes less thrombus but doesn't increase bleeding. But there's some very controversial because one study was stopped because it wasn't preventing strokes. So that's something we're looking forward to. Is there a better anticoagulation treatment which will not cause bleeding, which prevents strokes? And as I said, the first drug did not show that. So that was a disappointment. And then there are multiple agents for cholesterol reduction, which are advances, but we already have agents out there. So they're just a different agent, but I'm not as excited about those. You're welcome. Take care now. Bye-bye now.